actually has already been spoken by Dr. Rakesh Yadav. So because both the topics were so similar that he's mostly covered it. So let's have fun. Sudden cardiac death is such a serious topic. So I think we will have fun. We'll have a little. I have a couple of videos I want to show. So let's do that. So most of my colleagues here are intervention cardiologists. This is a case study for them. 58-year-old male, diabetic, hypertensive, occasional smoker, had chest pain for 2-3 days. He was not thrombolized. Echo showed ejection fraction of 28% with regional wall motion abnormality in the LAD territory and probably a clot at the apex. So what do we do next? This was the ECG with the patient presented. What do we do next? We do an angio, right? We all agree to this. So we did an angio. LAD was 100%. My intervention colleague did a beautiful job. Excellent job. You cannot have a better flowing LAD. And patient was discharged and somehow 28% ejection fraction, patient was put on a halter. And this is what the halter showed. So the only difference between syncope and sudden cardiac arrest is that you wake up from one. You do not wake up from sudden cardiac arrest, you wake up from syncope, and this is what happened with this patient, and he died. Now, what do? We don't do, we read such kind of news every day. We lost our own missile man, our past president, Shri Abdul Kalam ji, with sudden cardiac arrest. He was delivering a speech in an audience, and he collapsed. And nobody gave him a CPR also, so we lost him. There are so many news that are there. And sudden cardiac arrest, of course, is the biggest silent killer I have ever seen. I'm very scared of that. So the data shows that is actually the general population which is the biggest challenge. Because with our own problems, whether it is Bangladesh problem or India problem, right? The country has their own problems. We are still sitting at, dealing with famine, dehydration, child growth retardation and stuff like that. So sudden cardiac arrest actually does not come on our scenario at all. In India, this is one of very old study which was there. It has been presented by my friend Haigrave Rao, and this is from the southern India, and it shows that the overall contribution of sudden cardiac death is around 10% in south of India. Now, I told you we'll have a little fun, so let's see a football match. Who all are fond of football? Anybody? No? Yeah. We have people fond of football. So watch jersey number 29. A healthy guy, totally fit, playing, but sweating a lot. And he's doing fine. Suddenly he doesn't feel good. He doesn't feel good. And what happens? He collapses. And they are doing CPR. Unfortunately, they were not able to save him. Our heart is a miracle organ, but what happens in this miracle organ is actually beyond the understanding of many physicians who underrate sudden cardiac arrest and what it leads on to the heart. It just gives us 6 minutes to act and to react and to save a life. Defibrillation, availability of defibrillation is very good. We have been promoting CPR trainings, we have been promoting AEDs in our community, in our hospitals, amongst the staff, amongst bigger gatherings, even in schools. We have been trying to do that, to learn CPR, so that we can prevent and we do not repent. But ICD, of course, stands as the standalone therapy to save life. This is how it saves life. And let's look at another football match. I told you this is going to be fun, right? So you look at this, you see a player collapses, and just look at this. Yeah, he gets a shock. Did you see the movement of the leg? He got a shock, and he goes up and he starts to play again. So this is saving life. It's so wonderful. So why should we not give this therapy to the right candidates? Now, as we just discussed, primary prevention and secondary prevention, we have been talking of. Why give primary prevention here? We don't require it. But primary prevention saves life. The one SCA event that we are waiting for before considering ICD in such patients can actually be the last for that patient. And we should not take such decisions. We have to give benefit to the patient without doubts. We have already seen these slides. All the trials do show no medical therapy works as good as the ICD. And we have seen the guidelines, what they show us, and the numbers also. See, the earlier, even at government level, we were not approved for ICDs. Now we have that change from last couple of years. The government has started approving in patients who have government reimbursement to give ICD in these patients. At physician level, we are improving the awareness. We are going around giving more and more talks like this. And at patient level, it is still a challenge to tell them that they are doing fine, but they are still require an ICD therapy. The discussion that was going on between class 2 and class 4 patients, actually, we were made intelligent by Merit HF trial, which was the biggest trial on beta blockers. That trial showed that if you have class 4 patients, 60-70% will die of pump failure. But if you have class 2 patients, NYHA class 2 patient, very stable on medical therapy, guideline-directed medical therapy, 70-80% patient will die of sudden cardiac arrest. So that is the substrate that we have to deal with. And this is a European study which was published in Europace. The awareness of indications for device therapy among broad range of physicians. This was a survey done. Why ICD are not being promoted? The biggest cause that they found was that they are unaware of the indications at the physician level. So please spread this indication. It is very good. The 1.5 prevention is, of course, an acceptable thing in our country where we do not have so much of resources. So look at these patients with LV dysfunction. Choose the sicker patients. Choose patients who have ejection fraction something like 25%, who've had a syncope, who are throwing a lot of ectopics or NSVTs on Holter. At least offer them the ICD therapy and save life in these patients. Now, this study is a wonderful study which has come published by Dr. Rakesh Yadav. I always show this study with pride that it has come from India, where our Indian patients have been compared to the MADIT-2 therapy, MADIT-2 trial therapy patients. And they have shown that whatever we do, the SCA, the level of SCA that the Indian patients have is much higher than the European population. So I don't think so we need more of evidence than this, which is already there. And of course, guideline-directed medical therapy has improved. We have drugs like ARNI, we have SGLT2 inhibitors, which have improved the ejection fraction in the patients. But having said that, if ejection fraction remains less than 35%, despite guideline-directed medical therapy, patients should be given a device therapy. And over and above echo, I wouldn't say over and above, but it is complementing our echo and it is making us more intelligent, is the role of cardiac MRI to see what is the size of the scar in these patients. If the size of the scar is really huge, it is very big, then it is better to give even the very, stable patients an ICD therapy and give them the benefit of being saved from death. So cardiac MRI, use it more and more, you will really start to appreciate the advantage of that. Now, this summary is nothing new for you all. It is a class 1 therapy for patients, ejection fraction less than 35%. Now, let us discuss what is the actual scenario in my country, and I'm sure it is the actual scenario in this country also. This patient presented to me, 20 years old, beautiful girl. She was from North India. She is a Punjabi, Sardarni, I would say, from a Sardar family. She came with 2 episodes of syncope, a long QT on the ECG, and I documented this on the Holter, right? And I did, the family just kept coming in and out and saying all those things. Is it really necessary? Do we need to give a device therapy? What if we cannot give it? And then I got the genetic study also done. The genome lab sent us the report with the malignant gene in this patient for long QT syndrome. And I told the father of the girl that please let me give her an ICD. She needs that as a life-saving device. You know what was the answer? He answered me in our native language. She still has to get married. We have to get her married first. A 20-year-old beautiful girl, 4 months after this discussion, the girl passed away in sleep. We lost that patient. And I felt so bad. The father felt so bad. Now she has a brother again with the long QT syndrome. I have given him an ICD as a preventive therapy just last week. So in our family still, the boy gets the device, the girl doesn't. She has to be married first. But she has to live to get married. Am I right or am I right? Am I right? Yeah. Thank you so much for your patient hearing.
Thank you, madam, for your nice deliberation.